Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. In this video, we will localize lower motor neuron weakness by moving systematically from the anterior horn cell to the nerve root, plexus, peripheral nerve, polyneuropathy, neuromuscular-junction, and finally the muscle. We begin with the anterior horn cell. Anterior horn cells are the lower motor neurons located within the spinal cord. Loss of these motor neurons causes denervation of the muscles supplied by the affected spinal segments. The sensory fibers are not directly involved. Clinically, this produces pure lower motor neuron weakness. Look for muscle wasting, fasciculations, reduced tone, and reduced reflexes. Sensation should remain normal. The weakness does not follow the territory of one named peripheral nerve or a single dermatome. Instead, it follows a segmental or myotomal pattern because the anterior horn cells within particular spinal segments are affected. This helps distinguish an anterior horn cell lesion from radiculopathy. A nerve root lesion usually produces sensory symptoms in a dermatomal distribution, whereas an isolated anterior horn cell lesion does not. In PACES, you could say, there is segmental lower motor neuron weakness with wasting, fasciculations, reduced reflexes, and preserved sensation, suggesting an anterior horn cell disorder. Important examples include syringomyelia, motor neuron disease, spinal muscular atrophy, poliomyelitis, and acute flaccid myelitis caused by West Nile virus or enteroviruses. Remember that syringomyelia may damage the anterior horn cells at the level of the cavity and cause segmental wasting and weakness. However, if nearby crossing sensory fibers are also affected, the patient may have dissociated sensory loss. Motor neuron disease may produce anterior horn cell signs, but upper motor neuron signs can also be present because the corticospinal tracts may be involved. Spinal muscular atrophy is a predominantly lower motor neuron disorder. Poliomyelitis and acute flaccid myelitis typically produce acute or subacute flaccid weakness through damage to anterior horn motor neurons. We now move to the nerve root or radiculopathy. Compression or inflammation of a spinal nerve root produces weakness in a myotomal pattern, sensory symptoms in a dermatomal pattern, and reduction of the reflex supplied mainly by that root. The patient may describe neck or back pain radiating into the limb. Paresthesia, numbness, or pain follows a dermatome. The weakness affects muscles supplied by different peripheral nerves, but those muscles share the same nerve root. This is the key localization clue. For example, weakness involving both the biceps and wrist extensors cannot be explained by one peripheral nerve. However, both movements receive an important contribution from the C6 root. This supports a C6 radiculopathy. In PACES, you could say the combination of radiating spinal pain, myotomal weakness, dermatomal sensory symptoms, and loss of the corresponding reflex suggests a nerve root lesion. Let us review the typical root patterns. A C5 radiculopathy mainly causes weakness of shoulder abduction and may also weaken elbow flexion. The biceps reflex may be reduced, and sensory symptoms may occur over the lateral upper arm. A C6 radiculopathy causes weakness of elbow flexion and wrist extension. The biceps or supinator reflex may be reduced. Sensory symptoms commonly extend towards the thumb and lateral forearm. A C7 radiculopathy causes weakness of elbow extension, wrist flexion, and finger extension. The triceps reflex may be reduced, and sensory symptoms may extend towards the middle finger. An L4 radiculopathy may cause weakness of knee extension due to quadriceps involvement. The knee jerk may be reduced, and sensory symptoms may occur over the medial lower leg. An L5 radiculopathy commonly causes weakness of ankle dorsiflexion and great toe extension. This may present as foot drop. Sensory symptoms may occur over the dorsum of the foot. There is no consistently reliable deep tendon reflex for L5, so the pattern of weakness and sensory disturbance is particularly important. An S1 radiculopathy causes weak plantar flexion. The patient may have difficulty standing or walking on tiptoe. The ankle jerk may be reduced, and sensory symptoms may extend along the lateral foot. By this stage of the examination, you should already have assessed tone, power, reflexes, and sensation. The root pattern brings these findings together and allows anatomical localization. We now move to the plexus. A plexus contains fibers from several spinal roots that are being redistributed into several peripheral nerves. Therefore, a plexus lesion affects fibers from multiple roots and multiple named nerves simultaneously. The weakness and sensory loss do not fit one root, but they also do not fit one peripheral nerve. Pain is often severe, particularly in inflammatory, infiltrative, or ischemic plexopathies. Several reflexes may be reduced because more than one root and nerve pathway can be involved. In PACES, you could say, the motor and sensory abnormalities involve several peripheral nerve territories and cannot be explained by a single nerve root, suggesting a plexus lesion. An upper brachial plexus lesion, mainly involving C5 and C6 fibers, causes weakness of shoulder abduction, external rotation, and elbow flexion. This pattern may resemble an herb-type distribution. A lower brachial plexus lesion, mainly involving C8 and T1 fibers, causes weakness of the intrinsic hand muscles and finger flexion. Sensory loss may occur along the medial forearm and hand. A lower plexus lesion may also be associated with Horner syndrome if the sympathetic pathway is affected, particularly with an apical lung tumor. Parsonage-Turner syndrome, also called neuralgic amyotrophy, typically presents with sudden severe shoulder pain followed by patchy weakness and wasting around the shoulder girdle. Diabetic lumbosacral radiculoplexus neuropathy often presents with severe pain in the hip or thigh, followed by asymmetric proximal weakness and wasting. Weight loss may also be present. Other important causes include tumor invasion and radiation plexopathy. Tumor-related plexopathy is often painful and progressive. Radiation plexopathy may develop after radiotherapy and can be less painful, although the clinical context and investigations are needed to distinguish them. To understand plexus localization more easily, quickly revise the major root contributions and peripheral nerve distributions on this YouTube channel, because plexopathy is recognized by abnormalities that cross both of these boundaries. We now move to a single peripheral nerve lesion. Damage to one named nerve causes weakness and sensory loss, limited to the motor and cutaneous distribution of that nerve. The weakness fits the action supplied by that nerve rather than a complete myotome. Sensory loss occurs in the nerve's cutaneous territory. Radiating neck or back pain is usually absent because the lesion is distal to the nerve root. In PACES, you could say, the pattern of weakness and sensory loss corresponds to a single named peripheral nerve, suggesting a mononeuropathy. Common examples include median, ulnar, radial, common peroneal, and femoral neuropathies. A median nerve lesion may cause weakness of thumb abduction and opposition, with sensory symptoms affecting the thumb, index finger, middle finger, and radial half of the ring finger. The exact pattern depends on the level of the lesion. An ulnar nerve lesion may cause weakness and wasting of the interossi, impaired finger abduction and adduction, and sensory loss affecting the little finger and ulnar half of the ring finger. A radial nerve lesion may cause wrist drop due to weakness of wrist and finger extension. Sensory loss may occur over the dorsal first web space. A common peroneal nerve lesion causes foot drop through weakness of ankle dorsiflexion and eversion. Sensory symptoms may occur over the anterolateral lower leg and dorsum of the foot. Inversion is relatively preserved because tibialis posterior is supplied by the tibial nerve. This helps distinguish common peroneal neuropathy from an L5 radiculopathy, in which inversion may also be weak. A femoral nerve lesion may cause weakness of knee extension, a reduced knee jerk, and sensory loss over the anterior thigh or medial lower leg. When you identify a mononeuropathy, consider entrapment, trauma, diabetes, vasculitis, or leprosy. When multiple separate nerves become affected asymmetrically at different times, think of mononeuritis multiplex. This pattern is particularly important in vasculitis, diabetes, and certain infections. We now move to polyneuropathy. Polyneuropathy is generalized damage to multiple peripheral nerves. It usually begins in the longest nerves because their axons are the most vulnerable. Symptoms are typically symmetrical and begin distally in the feet. The patient may report numbness, burning, tingling, or neuropathic pain. Examination may show impaired vibration and joint position sense, distal weakness, and early loss of the ankle reflexes. As the neuropathy progresses, sensory symptoms move upwards in the legs. The hands become involved later, producing the characteristic stocking glove distribution. In PACES, you could say, There is a symmetrical, length-dependent sensory-motor peripheral neuropathy with distal sensory loss, distal weakness, and reduced ankle reflexes. Common causes include diabetic, alcoholic, and uremic neuropathy. These usually produce a chronic, symmetrical, length-dependent pattern. Guillain-Barré syndrome typically causes rapidly progressive weakness with reduced or absent reflexes. Weakness often begins in the legs and may ascend. Sensory symptoms may occur, but objective sensory loss can be relatively mild compared with the degree of weakness. Respiratory function and bulbar involvement must be assessed urgently. Chronic inflammatory demyelinating polyneuropathy, or CIDP, causes a more chronic or relapsing symmetrical neuropathy, often with both proximal and distal weakness, sensory impairment, and reduced reflexes. Charcot-Marie-Tooth disease is an inherited neuropathy. Look for long-standing distal wasting, pes cavus, hammer toes, reduced ankle reflexes, and a family history. Vitamin B12 deficiency may produce peripheral neuropathy, but it can also affect the posterior columns and corticospinal tracts. Therefore, the patient may have impaired vibration and proprioception together with upper motor neuron signs. The key distinction is that a typical polyneuropathy is bilateral, symmetrical, distal, and length-dependent. We now move to the neuromuscular-junction. Here, the motor nerve and muscle fibers remain structurally intact, but transmission of the signal from the nerve to the muscle fails. The main clinical feature is fluctuating or fatigable weakness. Sensation remains normal because sensory pathways are not involved. Wasting is usually absent or minimal, particularly early in the disease. Ocular and bulbar muscles are commonly affected. The patient may present with ptosis, diplopia, dysarthria, dysphagia, nasal speech, or fatigable limb weakness. Reflexes help with localization. They are usually preserved in myasthenia gravis, but may be reduced in Lambert-Eaton syndrome. In PACES, you could say, there is fatigable motor weakness with preserved sensation and no significant wasting, suggesting a disorder of neuromuscular transmission. Important examples include myasthenia gravis, Lambert-Eaton syndrome, botulism, organophosphate poisoning, and medication-related transmission failure caused by drugs such as aminoglycosides. In myasthenia gravis, weakness worsens with repeated use and improves with rest. Ocular and bulbar muscles are frequently affected. Pupillary function and sensation remain normal. Lambert-Eaton syndrome commonly causes proximal leg weakness, autonomic symptoms such as dry mouth, and reduced reflexes. Strength and reflexes may briefly improve after muscle activation. This is called facilitation. An important association is small cell lung cancer. Botulism may cause descending paralysis with cranial nerve involvement and autonomic dysfunction. Pupillary abnormalities may occur. Organophosphate poisoning can cause neuromuscular weakness alongside muscarinic features such as sweating, salivation, bronchial secretions, diarrhea, and pinpoint pupils. Aminoglycosides may impair neuromuscular transmission, particularly in susceptible patients, or when combined with other neuromuscular blocking factors. The practical memory hook is that myasthenia worsens with repeated use, whereas Lambert-Eaton may briefly improve after activation. Finally, we move to primary muscle disease. In myopathy, the muscle fibers themselves are abnormal. The motor nerves, neuromuscular junctions, and sensory pathways remain intact. The usual pattern is symmetrical proximal weakness. Patients struggle to rise from a low chair, climb stairs, get up from the floor, lift their arms above their head, or comb their hair. Sensation remains normal. Reflexes are generally preserved until the weakness becomes severe because the reflex arc remains intact. Fasciculations are absent because there is no active denervation of motor neurons. In PACES, you could say, there is symmetrical proximal weakness with preserved sensation and reflexes, suggesting a primary myopathy. Important causes include polymyositis and other immune-mediated myopathies, dermatomyositis, inclusion body myositis, muscular dystrophy, steroid myopathy, hypothyroid myopathy, and mitochondrial or metabolic myopathies. Immune-mediated inflammatory myopathies usually cause subacute proximal weakness. Muscle pain may or may not be present. Creatine kinase is often elevated, although the degree varies between conditions. Dermatomyositis causes muscle weakness together with characteristic skin changes, such as a heliotrope rash, Gottron papules, or a photosensitive rash. Inclusion body myositis is an important exception to the usual symmetrical proximal pattern. It often causes asymmetric weakness, particularly involving the quadriceps and deep finger flexors. It progresses slowly and commonly affects older adults. Muscular dystrophies are inherited disorders and may be associated with a long-standing history. Calf enlargement, contractures, scapular winging, or characteristic patterns of weakness. Steroid myopathy usually produces painless proximal weakness. Creatine kinase may remain normal, which helps distinguish it from many inflammatory myopathies. Hypothyroid myopathy may cause proximal weakness, muscle discomfort, delayed relaxation of reflexes, and other clinical features of hypothyroidism. Mitochondrial and metabolic myopathies may present with exercise intolerance, episodic weakness, cramps, or involvement of other organs. The main localization clue is proximal weakness without sensory loss, fasciculations, or early loss of reflexes. Therefore, when localizing weakness in PACES, use the pattern. Segmental pure lower motor neuron weakness with fasciculations suggests anterior horn cell disease. Myotomal weakness with dermatomal sensory symptoms suggests a nerve root lesion. Findings crossing several roots and nerves suggest plexopathy. Weakness and sensory loss within one named nerve suggest mononeuropathy. Bilateral symmetrical length-dependent abnormalities suggest polyneuropathy. Fluctuating fatigable weakness with normal sensation suggests neuromuscular-junction disease. Symmetrical proximal weakness with preserved sensation and reflexes suggests myopathy. Do subscribe to the channel for further videos.